1. Tragic consequences. 6 patient deaths linked to physician associates in NHS. 2. The need for change. Renaming physician associates in healthcare. 3. Family criticizes Govt review after woman's death due to misdiagnosis by a substitute doctor. 1. Tragic consequences. 6 patient deaths linked to physician associates in NHS. The recent revelation of 6 patient fatalities associated with the involvement of physician associates in the NHS has raised significant concerns within the healthcare community. This alarming situation underscores the critical importance of ensuring that all healthcare professionals, including physician associates, are adequately trained and supervised to prevent such tragic outcomes. But here's where it gets controversial. The role of physician associates in patient care is still a topic of heated debate. Some argue that these professionals fill essential gaps in healthcare delivery, while others question their qualifications and the potential risks involved in their practice. In a related matter, we must address an important notification regarding your subscription. It appears that we have encountered difficulties in processing your payment. To ensure uninterrupted access to our services, please take a moment to update your payment information. You can easily do this by visiting the My Account section, or by clicking on the Update Payment Details link provided. Act now to maintain your subscription and avoid any disruption in service. We have made several attempts to reach out to you regarding this issue, and it is crucial that you update your payment details promptly. Failure to do so will result in the termination of your subscription, which we would like to avoid. This situation serves as a reminder of the importance of staying informed and proactive, both in healthcare and in managing your subscriptions. What are your thoughts on the role of physician associates in patient care? Do you believe they are a valuable asset to the healthcare system, or do you have concerns about their impact on patient safety? We invite you to share your opinions in the comments below. 2. The need for change. Renaming physician associates in healthcare. Imagine walking into a clinic thinking you're seeing a doctor, only to later discover it was someone with less training and fewer qualifications. That's the heart of a growing debate in healthcare, and now a government-commissioned review is urging a complete overhaul of how certain medical professionals are labeled and regulated. Here's why this matters, and why the conversation is far from settled. The report, led by Professor Gillian Ling, argues that physician associates, PA, and anesthesia associates, AAs, should no longer use titles that might confuse patients. Instead, they should be called physician assistants to clearly signal their supportive role in medical teams. But here's where it gets controversial. The review also recommends strict limits on their responsibilities. For instance, PA should only see patients who've already been triaged and deemed to have minor issues, no more handling initial diagnoses or critical decisions. And to work in a GP surgery or mental health trust, they'd need at least 2 years of hospital experience first. This isn't just about semantics, it's about safety. As Professor Ling explains, when these roles were introduced in 2000, there was no clear national plan. Teams were thrown together without guidelines, leading to confusion and, in some tragic cases, preventable deaths. Take Emily Chesterton, a 30-year-old woman whose calf pain was misdiagnosed as a sprain by a PA in 2022. In reality, it was a blood clot that claimed her life. Or Susan Pollitt, 77, who died from an infection after a drain was left in her abdomen far too long during a PA's care. Her daughter, Kate, recalls the chaos of hospital visits. You're not thinking straight, you just want your loved one to be safe. Even if they tell you their title, you don't register it. These stories aren't outliers. The review highlights a pattern. Most safety concerns stem from PA making diagnoses or starting treatments, where the risk of missing rare but serious conditions is highest. So what's the solution? The report outlines a laundry list of changes: standardized uniforms and badges to distinguish PA from doctors, clearer patient information about their role, and a dedicated faculty to set training standards. Health Secretary Wes Streeting has pledged to adopt all recommendations, insisting patients can be confident those treating them are qualified. Yet, not everyone agrees. The British Medical Association, BMA, says the rules still don't go far enough to define boundaries between PA and doctors. Dr. Emma Runswick of the BMA calls the name change positive, but adds, it doesn't fix the bigger issue of blurred lines in responsibilities. And this is the part most people miss. The pushback isn't just from doctors. The United Medical Associate Professionals, UMAPs, which represents PA and AAs, worries the new restrictions could worsen NHS waiting lists. Stephen Nash, UMAP's General Secretary, argues that limiting PA to only treat pre-diagnosed patients negates the very reason they were hired, extra hands in understaffed clinics. Meanwhile, critics on social media have fueled a firestorm of unsubstantiated claims about PA, prompting the Academy of Medical Royal Colleges to demand this review in the first place. Let's break down the basics. PA and AAs aren't doctors. They can't prescribe medication, but they can order scans, take medical histories, and perform exams. Their training is rigorous, 2 years of postgraduate study after a science degree or healthcare qualification, but it's not equivalent to years of medical school and residency. Anesthesia associates, AAs, a smaller group, assist surgical teams. Today, there are over 3,000 PA and AAs in England, with plans to grow to 12,000 by 2036. Both roles are regulated by the General Medical Council since 2024, but gaps in oversight remain. Here's the crux. Can we trust these roles to improve healthcare without compromising patient safety? The answer likely lies in balance. As Dr. Hilary Williams of the Royal College of Physicians notes, the review is thoughtful, but shows urgent reform is needed to ensure safe teamwork. The question is, do the proposed rules strike that balance, or are they another step toward a system where patients can't tell who's qualified to save their lives? Share your thoughts. We'd love to hear if you think these changes are overdue, or if they'll create more problems than they solve. 3. Family criticizes Govt review after woman's death due to misdiagnosis by a substitute doctor. A single misjudgment can change everything, and in the tragic case of Emily Chesterton, it cost her life. But here's where the debate intensifies. Are current healthcare policies truly protecting patients, or is the system falling dangerously short? Emily's parents, Marion and Brendan Chesterton, are speaking out after their daughter's fatal blood clot was mistaken for anxiety, not by a doctor, but by someone Emily believed was. Despite accepting several proposals outlined in Professor Gillian Ling's recent government-commissioned Review of Physician Associates, PA, within the NHS, the Chestertons argue these changes don't go nearly far enough. They describe the review as a missed opportunity to fully address the risks at stake. Let's rewind. Emily, a 30-year-old actress from Salford, visited her North London GP surgery on 2 separate occasions in the weeks leading to her death in November 2022. Each time, she was examined by a PA, not a fully qualified doctor, who failed to identify her blood clot, and instead prescribed propranolol, a medication typically used for anxiety. Tragically, Emily told her parents she had been treated by a doctor, genuinely believing that was the case. If we'd known she was seen by a physician associate, we would have insisted she saw an actual doctor, her father Brendan shared with reporters. Now, the government has responded with a sweeping review led by Professor Ling, president of the Royal Society of Medicine. The findings propose that physician associates should be prohibited from diagnosing any patients who haven't first been assessed by a doctor for their condition. This recommendation marks a critical shift for PA, considering their substantially shorter medical training compared to doctors, and the fact that they have at times been used as substitutes. Currently, more than 3,500 physician associates and 100 anesthesia associates, AAs, work for the NHS, with previous strategies even pushing for more hires. However, the medical community remains divided. High-profile patient deaths linked to misdiagnosis by PAR-fueled Health Secretary was Streeting's decision to commission this review in the first place. Professor Ling made her position clear. It's essential that PAR don't see patients whose conditions haven't been sorted or triaged. If a patient has been properly triaged, PAR may only see adults with minor concerns, under strict guidance from the Royal College of GPS, she explained. She stressed the need for national protocols to clarify exactly which patients PAR can attend, noting that shifting responsibilities, without clear boundaries, risks creating confusion and endangering patients. And this is the part most people miss. Professor Ling also called for PAR to be renamed physician assistants, to better represent their intended supportive role alongside doctors, not as their replacements. She advocates for distinctive uniforms to help patients clearly identify whether they are being seen by a doctor, PA, or AA. In addition, she suggested that AAs be rebranded as physician assistants in anesthesia. Another crucial proposal, newly licensed PAR should be required to gain experience within hospitals for 2 years before being allowed to practice in general practices or mental health trusts. Research suggests many patients are happy with care from PAR, but a significant number are unaware that their medical professional is not an actual doctor. Notably, Professor Ling concluded there's no hard evidence to justify eliminating the PA or AA roles altogether. However, she emphasized that the status quo is unsustainable and must change to ensure patient safety. Consider this. 6 patient deaths in England have now been officially tied to contact with PAR, as documented by coroners. Emily's mother Marion believes that if the review's recommendations had been in place earlier, her daughter would be alive today. I think so, yes. That's why this review is so important to us, she said, underscoring both grief and hope. But she's not satisfied. Mrs. Chesterton believes even stronger measures are needed, such as a blanket ban on PAR prescribing medication. To us, it's a missed opportunity. Our daughter was given a drug she should never have received, with catastrophic consequences. Can't we prevent this from happening to others? Their concerns echo across the wider medical community. Dr. Emma Runswick, Deputy Chair of the British Medical Association, BMA, points to ongoing confusion between the responsibilities of doctors and PAR. She commends efforts for clearer job titles and uniforms, but insists that as long as PAR are used as doctor substitutes whenever local managers choose, patient safety remains at risk. Conversely, UMAPs, the union representing PAR and AAs, sounds the alarm on another front. They argue these reforms would unjustly undermine their qualifications, worsen NHS waiting times, and heighten disruption during doctor strikes. By pandering to one group at the height of strike action, we're exposing patients to greater risk, says the union's General Secretary, Steve Nash. In a strikingly controversial statement, he even labeled the BMA, the biggest patient safety risk out there right now. Health Secretary Wes Streeting stands by Professor Ling's recommendations, promising swift adoption. We're implementing the Ling review in full. It provides much-needed clarity for the public. Patients can once again be sure those treating them are properly qualified. Physician assistants will continue playing a valuable role in the NHS, but must always support, and never replace, doctors, he stated. The government's upcoming plan for change will build upon these findings to benefit both staff, and most importantly, patients. But here's the question stirring the NHS. Are these new measures enough to guarantee patient safety? Or are we likely to see another missed warning? Is more radical reform needed? Can physician assistants ever be trusted to take on more responsibility? Or should their role always be strictly limited? We want your perspective. Do you agree with these changes? Or are you as worried as the Chestertons and the BMA? Or do you believe the unions have a point about undermining valuable workers and stretching NHS capacity? Share your thoughts below. Let's keep this vital conversation going.